Hello, and welcome to the Oncology Nursing Society's Leadership Webcast Series, and today's presentation entitled Precepting the New Nurse, Orientation and Competency for Oncology Nurses. The planners and presenters of this webcast have disclosed no financial relationships with any commercial companies pertaining to this activity. There will be no discussion of off-label product use, and there is no commercial or non-commercial support for this presentation. I am pleased to introduce today's speaker. Carrie Mahar is a clinical nurse specialist at Dana-Farber Cancer Institute in Boston, Massachusetts. In her 21 years of nursing experience, she has worked as staff nurse, hospice nurse, clinical nurse specialist, and in medical affairs for a pharmaceutical company. More than half of her career has focused on nursing education and staff development. Welcome, Carrie.
Hello. In the next 45 minutes or so, I'll be talking about the challenges and considerations of precepting nurses in the oncology setting. I'll speak to the following objectives: describe the considerations required to orient new and experienced nurses to an oncology setting, identify the important characteristics and skills a preceptor needs to facilitate orientation to the workplace, and to describe the resources and technology available to new nurses and their preceptors. As we begin, I'd like to address some definitions. The words orientation, competency, preceptor, mentor, and the term adult learning are thrown around so much and have come to have different meanings to different people. First, let's discuss the idea of what a new nurse is. We all know that the need for nurses is becoming greater and greater. Despite that, many of us are feeling not only a shortage, but reduction in staff. Some areas are affected by the local economy, and the result is nurses who had nice, secure positions are now forced to change hours and roles. No matter, there will always be new nurses to orient. The question is, who is that new nurse going to be? And what does she or he need to get oriented to the role? A new nurse these days can come from any kind of a background and alternative experiences. This variation has its challenges and, of course, pluses. Some new nurses are new graduates. That's probably the traditional. Someone who went from high school to a baccalaureate or other nursing preparation program. New graduates with previous work. Very common scenario. Someone who decides on nursing as a career choice after trying out something else. Also could be someone who had to leave a job or position for financial reasons and sees nursing as a way to make a half-decent wage and hopefully make a difference. And then we have travelers. Most travelers are very experienced nurses, sometimes in a particular specialty area, who are expected to quickly orient to a position and be independent within a very short amount of time. Sometimes the practice of a traveler is limited to allow this, i.e., no blood transfusion, no chemo administration, no specialty care. When we talk later about the process of orientation, keep this type of employee in mind, in particular when we talk about socialization. Transfer from another area. In an institution, units close, open, expand, or become smaller. Staff transfer to other areas due to staffing changes or due to a desire to make the switch for professional reasons. The reason for the transfer can impact both on the relationship between the orientee and the preceptor and how well the orientation flows. Then there are older nurses going into new roles, very similar to a transfer. This could be a change from night shift to days, staff nurse to charge nurse, general oncology care to palliative care or transplant care. Then there are foreign educated nurses. Occasionally there may be new hires who are not trained in the U.S. So basic nursing skills may differ, and English as a second language is something to be considered. LPNs and assistive personnel also need to be oriented. Although there are fewer LPNs around, they do certainly still come around and need to be oriented. It's not uncommon for a staff nurse to initiate the orientation of assistive personnel, like a clinic assistant or nursing assistant, prior to them being oriented by a clinic assistant or nursing assistant in that role already. Then they have students. students are everywhere. Students of all types of programs need to be precepted in a clinical setting. Most often, the final term of an RN program requires this type of experience to allow for immersion into the role of the staff nurse. Graduate students are often paired with like roles, nurse practitioner, clinical nurse specialist, or even in administration. Faculty also need to be required. New hires or staff transitioning to clinical leadership roles like CNS or a manager often need to spend time in the clinical areas to observe practice and get a sense of staffing and resources at the patient care level. The ability for institutions to educate and prepare these numbers is overwhelming, if not impossible. Who doesn't know someone or hasn't themselves taken part in online education for a degree? The ANA describes the three purposes of orientation as competency, socialization, and role transition. The primary emphasis during orientation is on assessing, validating, and developing specific competencies that are needed for a nurse to effectively function in the role. Most orientation programs are competency-based. This means that the functions of a particular role are outlined, often on a sign-off sheet, to allow a preceptor or educator to verify the competent demonstration of the particular task, including knowledge and skill related to that task at hand. For instance, a component of the role may include the administration of red blood cells. A preceptor will review the policy and procedure with the orientee. The orientee will observe and assist with the blood product administration several times before attempting to do it independently. Once the orientee demonstrates the entire procedure, from taking off the orders, checking the consent, etc., to taking down and discarding the empty bag and tubing and documenting the administration, the preceptor will sign off that he or she is competent. It may take several doings of the task before the sign-off, but that's pretty much the process. Progression through this CBO, or clinical competency-based orientation, can vary in time. Factors include previous experience, preceptor skill and comfort, more on that later, and time allowed. Some programs have formal progression, i.e. working with acute care or symptom management before moving on to chemotherapy administration or bone marrow transplant care. Socialization is much more than making friends at work. It's the learning of how to fit into a dynamic that already exists. Benner uses the term formation because it denotes development of perceptual abilities and the ability to draw on knowledge and skilled know-how in a way of being and acting in practice in the world. Think of a new grad suddenly thinking, I'm a nurse now. This is part of my identity. How does that change my persona, which includes perhaps mother, daughter, aunt, wife, Christian, volunteer, etc.? For the new nurse, formation takes time with the transformation of layperson to skilled provider of care and how to interact with patients and coworkers as a provider of care, as a colleague. The transition of role can be from student to nurse, from fairly new nurse to oncology nurse, from experienced nurse to new oncology nurse, or even from specialist in one area to specialist in another area. We always have to consider the knowledge base and experience a new nurse comes to us with. An experienced, extremely competent ICU nurse can struggle even more than a new graduate. Dealing with being a novice again is something that they may be ill prepared for. Many organizations use the competency-based orientation model. The organization defines the competencies, and demonstration of these competencies indicates the orientee has successfully completed orientation. An orientation program will often include education programs that the new nurse must attend or complete along the way. A good example of this is to attend and successfully pass the test of the ONS chemotherapy and biotherapy course. An experienced nurse may do this sooner than later in his or her orientation. A new graduate may work for 6 months, so even be through his or her formal orientation period before completing this particular component. Determining what the competencies are for a particular role are identified ultimately by the organization, but also by accrediting agencies. For instance, the Joint Commission has specific language that those caring for patients must receive some education or training regarding fire and safety, hazard material management, age-specific patient care concerns, or pain assessment and management, to name a few. Other agencies that influence competencies are OSHA, regarding environmental safety, and the ANA, regarding Nurse Practice Act. Risk, volume, and problem areas also drive the competencies that are included or may influence the order they are completed in. High-risk competencies are those that can seriously injure a patient if performed incorrectly. Chemotherapy in a busy ambulatory clinic would be considered high risk, high volume. Nurses on a head and neck surgical floor would have tracheotomy care as a high risk, high volume competency. High risk, low volume might include blood transfusions in a transitional care unit where they may not give it very often but do have to give it. The next level of priority may go to those specific areas or problems identified by the institution, for instance, as a result of safety report data or Press Ganey results. So there may be emphasis on medication error prevention or dose calculation or falls prevention included in the CBO. The evaluation criteria must be clear and obviously well known. They should be learner-centered and describe the behavior in measurable and observable terms. Understands the policy for safe handling chemotherapy is not the same as demonstrates the proper handling and disposal of chemotherapy in the clinic. The standard for comparison is most often the institution's policy and procedure manual. More area-specific standards may also be in place, i.e., a unit-specific standard for mouth care. The idea of partnering a new nurse with an experienced nurse in order to learn in the work setting has been the practice since nursing became a formal profession. Pat Benner identified the continuum of novice to expert in 1984. This has been the hallmark frame of reference for nursing when thinking about clinical knowledge level or expertise. A preceptor is a nurse with a reasonable amount of clinical expertise and interest, a very important point. A preceptor provided one-on-one teaching, guidance, and support, and very importantly, serves as a good role model. We'll talk about these characteristics and others in a few minutes. In the 80s, Pat Benner defined the continuum of novice to expert to describe the experience and learning stages and readiness of nurses. Knowing where both the preceptor and the orientee are on this continuum is extremely helpful in establishing learning goals and how to meet them. Just going to take a few minutes to describe the stages of learning. Stage 1 is novice. Novice beginners have had no experience of the situation in which they are expected to perform. Novices are taught rules to help them perform. The rules are context-free and independent of specific cases. Hence, the rules tend to be applied universally. The rule-governed behavior typical of the novice is extremely limited and inflexible. To quote a novice, they would say, just tell me what I need to do and I'll do it. Stage 2 would be advanced beginner. Advanced beginners are those who can demonstrate marginally acceptable performance, those who have coped with enough real situations to note or to have pointed out to them by a mentor the recurring, meaningful situation components. These components require prior experience in actual situations for recognition. Principles to guide actions begin to be formulated. The principles are based on experience. Stage 3 is competence. This is typified by the nurse who has been on the job in the same similar situation for probably about 2 or 3 years. It develops when the nurse begins to see his or her actions in terms of long-range goals or plans. The competent person does not yet have enough experience to recognize the situation in terms of an overall picture or in terms of which aspects are most salient or most important. Stage 4 is proficient. A proficient performer perceives situations as wholes rather than in terms of chopped up into parts or aspects, and performance is guided by maxims. Proficient nurses understand a situation as a whole because they perceive its meaning in terms of long-term goals. There is a holistic understanding which improves the proficient nurse's decision-making. It becomes less labored because the nurse now has a perspective on which of the many existing attributes and aspects in the present situation are the important ones. And then lastly, stage 5 is the expert. The expert performer no longer relies on an analytical principle, such as rules, guidelines, or maxims, to connect her or him, his understanding of the situation to an appropriate action. The expert nurse, with an enormous background of experience, now has an intuitive grasp of each situation and zeroes in on the accurate region of the problem without wasteful consideration of a large range of unfruitful alternative diagnoses and solutions. The expert operates from a deep understanding of the total situation. This is not to say that the expert never uses analytical tools. Highly skilled analytic ability is necessary for those situations with which the nurse has had no previous experience. The main difference between a mentor and a preceptor is that a mentor is much more like a consultant. The learner or mentee needs to be in a more independent phase of their orientation or work. A mentor can be a role model for education, clinical practice, or leadership skills. Mentors are most often selected by the learner because he or she has observed and seen the person's practice and admires it. He or she wants to aspire to work like that. Mentors do not necessarily need to be in the area where the mentee is. In fact, not even in the same institution. Mentors can coach, support, advise, and help another reach his or her potential from across the hall or across the country. Mentoring entails the formation of a relationship or partnership between the mentor and the mentee. A foundation of trust between both partners is the key to a successful mentor-mentee relationship. Each partner must be willing to devote time and energy to the mentoring process. The mentor acts as a role model and an advocate to pass on life experiences and knowledge in order to motivate, support, and enhance the mentee in his or her personal and career development. A good mentor has leadership experience, is available and responsive, believes in the capabilities of the mentee, has vision, and knows how to access professional networks. The mentee exhibits a desire for job success and seeks challenging assignments and new responsibilities. The mentee actively seeks the advice and counsel of an experienced nurse mentor and is open to changing practice or ideas regarding standards of care. Andragogy is the art and science of helping adults learn. Please refer to the references that I'll list later for more detailed descriptions of learning theory. Today I just want to emphasize those points that a preceptor needs to keep in mind in her day-to-day planning activities. I'm sure you've heard this before, but adults, unlike children and adolescents, learn and comprehend differently. The major difference is that adult learning theory is based on the concept that learners take the responsibility of learning and the use of resources. In the pedagogical-oriented environment, the teacher is the transmitter of knowledge with the student assuming a more passive role. Think of adult learning as problem-centered, how best to manage a patient's pain, versus adolescent learning, which tends to be subject-centered, like how to solve a math problem. The prime motivator to learn in adulthood is to be able to apply knowledge and skills for the solution of the immediate problems. Adults must clearly perceive the relevancy, the why, in acquiring new behaviors or changing old ones for them to be willing and eager to learn. With this, they are more self-directed in terms of finding the way to learn about something. An adult is more self-directed and independent in seeking information. As we learn through our lives, past experiences are stored and called upon to compare and contrast how things worked or didn't work and how the current problem or experience compares to that experience. Relationships of trial and error come in much easier to an adult. Readiness and motivation often come in hand. Optimally, the learner orientee is physically, emotionally, experientially, and knowledge ready to learn. Physical readiness includes that the environment is conducive to learning, not in a crowded hallway, for instance, that their personal health status allows for learning to perform a manual task. Emotional readiness may include that the anxiety level is not too high and that their frame of mind is that they're engaged and that they're invested. Experiential readiness can mean that they're coping with the change in the work status, the hours of work, and the orientation is on schedule. And then knowledge readiness means that their present knowledge base is adequate for the orientation and that their learning style is being met. Motivation and emotional readiness truly are attached at the hip. To be motivated is to intend to improve. Otherwise, it's just going through the motions, and learning and behavior changes don't occur. What type of person makes the best preceptor? Think about people who have precepted you in the past, good, bad, and indifferent. What was it that made the good ones good and the bad ones bad? First of all, the best preceptor is not always the most experienced nurse on the unit. The essential qualities of a good preceptor can apply to someone with only a few years of experience. Those qualities, which we will discuss at more length in the next slide, include education. Usually a BSN or an MSN is often required in an institution for someone to precept a new hire. Clinical expertise. They need to be adept and able in the particular area. No, the preceptor doesn't have to know everything, but should be familiar enough with the practice that she or he isn't double-checking herself all the time, checking the policy and procedure every time. They need to have effective communication skills with all roles. They need to be able to communicate with nurse leaders, with physicians, support staff, peers, patients, and of course with the orientee. They need to have good interpersonal skills. They need to be a very good listener, and they need not to interrupt. They need to have leadership and role model qualities. It's not uncommon for someone to be a member of a leadership or task force or committee, or in the charge role. Many of the preceptors that I utilize in my practice are often the go-to person on that particular unit. They need to be willing to participate and interested in helping new nurses. That should be a given. It's helpful if they've had past experience with teaching, but that can be worked on. And they need to be able to create a positive learning environment. In particular, looking for experiences like, oh, there's a chest tube or line dressing or PCA pump that needs to be setting, and be very proactive for that orientee. They need to delegate and assign based on the orientee's needs, not on the staffing needs. Many institutions provide and very often require attendance at a preceptor preparation program or workshop. Whether from a program or from work experience or advisement from a mentor or a clinical educator, the preceptor must know or be aware of the following concepts. Understanding the role and responsibility of a preceptor. Understanding the job description of the orientee. How to teach effectively in the clinical setting. How to work with adult learners. How to understand and work with various learning styles. Maintaining effective communication skills. Evaluation and documentation of clinical performance, dealing with conflict in the clinical setting, maintaining confidentiality and ethics, demonstrating an optimistic attitude in a stressful situation, role modeling professional behavior in difficult circumstances, understanding the impact of culture on learning, and how to determine appropriate patient care assignments based on orientee abilities. With all that, who would agree to be a preceptor? Well, they need support and help and rewards. Managers, administrators, peers, and clinical educators are mentors and direct support for the preceptor. Many orientation models include a schedule of meetings with the unit educator, manager, preceptor, and orientee to maintain communication about progress and allow discussion of issues or concerns. Precepting is not having an extra set of hands. It's much more work added onto a clinical assignment. Formal recognition programs or cards or even pay differentials offer a gesture of gratitude. A preceptor must be able to provide the following in an effective manner. On any given day, the preceptor is performing all these functions. Communication. The primary goal of communication is to clearly exchange important information from one person to the other. Expectations of role performance or competency demonstration must be very clear and concise. Generalizations like, make sure everything is okay for Mrs. Jones's cisplatin administration, are too vague, and for the more novice learner, very confusing. Rather, let's verify that the patient's labs are within the parameters to treat and that she's had her baseline audiogram before we start that chemotherapy would be much more clear. Modeling. An effective preceptor doesn't just talk the talk, she needs to walk the walk too. Who hasn't heard someone explain that, yes, the policy says we do it that way, but, we do it this way here. Preceptors must model the right way to care for patients, communicate with the care team, document, interact with patients, etc. on a consistent basis, not just because they are a preceptor. And feedback. A preceptor needs to be able to elicit and provide feedback. Subjective feedback happens. A patient responds well to an interaction. The dressing stays intact. Objective feedback is something that requires the preceptor to evaluate the behavior based on the standard of care and communicate back how well the thing was done. Noting that sterility was compromised during a dressing change or the documentation was complete or not. Also, communicating on how the orientee is progressing in their orientation. Delegation. Along the orientation continuum, the preceptor must discern how much to delegate to the orientee. Certainly based on ability, but also knowing that ability is proven through doing, the orientee is given patient care responsibilities. This can range from observing the preceptor providing care to fully delegating all patients and their care needs assigned to the preceptor. The preceptor still remains responsible for the provision of the care, thus is assessing, monitoring, and giving feedback throughout the day. Advocacy. The preceptor may act as an advocate for the orientee. Staff not involved in the orientation process may see or hear things that seem odd or not up to a particular standard. Talk ensues, and all of a sudden the preceptor is approached about problems or issues that might be going on with the orientee. The preceptor must be able to rectify misconceptions and speak on the orientee's behalf regarding their progress and performance during orientation. And support. In addition to delegating to the orientee, the preceptor must provide or ensure the appropriate environment and resources are available, allowing the orientee to present or be present at morning rounds with the preceptor at hand for encouragement and supplementation as needed. And finally, a mentor. When we talked about mentoring before, it was to differentiate it from a preceptor. Well, as an orientee nears the end of their orientation, it's not uncommon for the preceptor to become a mentor, often for the period the two work together and even as people move on to other positions or institutions. The preceptor-orientee dyad is not out there alone, figuring things out. Guidance and expectations come from the institution, leadership, patients, and families and coworkers. Managers and unit or institutional educational team members determine what physical resources can be made available to the preceptor. Textbooks, manuals, models, videos. Access to electronic learning modules are made available often based on finances and ability to allow for time away from patient care. Clinical skills labs are getting more and more sophisticated. Fitting activities of learning, if you will, into orientation of a new staff member takes the coordination of the preceptor, clinical nurse specialist, manager, and senior staff and the recognition of where in the orientation experience these activities will best serve the orientee. For instance, it makes little sense for a new orientee to follow a bone marrow transplant patient down to radiation therapy for their TBI if he or she has not yet been introduced to the structure and flow of the care of the transplant patient. Regular meetings with the manager and clinical nurse specialist or unit-based educator are very important. In addition to monitoring the orientation flow, they can help identify issues and concerns that may not be apparent to the preceptor or the orientee. One thing I haven't mentioned is fit. Some people fit together better than others. Managers and CNSs can troubleshoot and even make changes in assignments of preceptor if needed. Personalities can clash. Timing can be off. The preceptor may have just oriented another new hire and is stressed or really needs a break. Emphasis should not be on the failure of the assignment, but on the need for best fit for all parties involved. Simulation is a method whereby an artificial or hypothetical experience is created that engages the learner in an activity that reflects real-life conditions, but without the risk-taking consequences of an actual situation. Types of simulation include games, models, role-playing, case study discussions, and yes, a learning lab. This picture is of me demonstrating the blood culture draw procedure at my institution using a fake arm and fake blood. Learning labs have evolved from a mock patient care area where students pretend to be patients to a computerized setup involving mannequins, computers, paging systems, medication administration, and even documentation. Emergency responses, dressings, physical assessment can all be evaluated in this type of an environment. New hire orientation may have simulation programs integrated into the process. For instance, many institutions will preempt unit-based orientation with performance-based scenario simulations that are meant to evaluate critical thinking and basic knowledge of nursing care. In turn, the unit educator, manager, and preceptor can get a better sense or more exact sense of needs and strengths of the new hire. E-learning is a term to describe all forms of electronically supported learning and teaching. Computer-based learning, sometimes abbreviated to CBL, refers to the use of computers as a key component of the educational processes. While this can refer to the use of computers in a classroom, the term more broadly refers to a structured environment in which computers are used for teaching purposes. Assessing learning in the CBT usually comes in the form of multiple choice questions or other assessments that can be easily scored by a computer, such as drag and drop, radial button, simulation, or other interactive means. Assessments are easily scored and recorded via online software, providing immediate end-user feedback and completion status. Users are often able to print completion records in the form of certificates. CBTs provide learning stimulus beyond traditional learning methodology from textbooks, manuals, or classroom-based instructions. For example, CBT offers user-friendly solutions for satisfying continuing ed requirements instead of limiting students to attending courses or reading printed manuals. Students are able to acquire knowledge and skill through methods that are much more conducive to individual learning preferences. CBTs can be a good alternative to printed learning materials since rich media, including videos or animations, can easily be embedded to enhance the learning. Another advantage is that they can be easily distributed to a wide audience at a relatively low cost once the initial development is completed. CBTs pose some challenges as well. Typically, the creation of effective CBTs requires enormous resources. Software, expertise in the particular specialty areas need to be considered. In addition, the lack of human interaction can limit both the type of content that can be presented as well as the type of assessment that could be performed. E-learning should be kept in its own context and be used in concert with other educational efforts. So lectures and workshops and demonstrations are not going to go away. I just had to include this picture of me and my dog. It's a good picture to show that it does take two to get the job done. As you can see, my dog does not want to go over that, but she finally did jump. Both parties need to be willing to work on the task at hand. Whether it's getting oriented to the new job, we need to understand what each person brings to the event. So to summarize, today we discussed and reviewed the key components regarding orientation of new staff and the role of the preceptor. This included describing what a new nurse is, the characteristics of an effective preceptor, and some of the resources available to orientees and preceptors in the process. Thank you for participating in this program. It was my pleasure to share with you. Good luck in your leadership advancement. Here's a list of some very helpful resources. Be sure to check out the resources also available online at ons.org.
Thank you, Carrie, for sharing this important and helpful information. As mentioned at the beginning of this program, participants can earn continuing nursing education by completing the post-test and evaluation found in the ONS Evaluation Center. You may access this information through the ONS Leadership Virtual Community. Thanks and have a great day.